Good morning, ladies and gentlemen. Good morning, everybody. Good morning. Good morning.
Good morning.
Good morning. Yeah, please, how are you all?
We are doing well. How about you?
Yeah, I'm fine. Yeah, I'm also managing. Please, the normal labor.
We are fine.
Thank you very much. Please, where did we end the last lectures? Normal labor. I assigned you to read on something. Please, did you read through?
Yes, we did.
Yes, sister.
Okay, then somebody to share your experience, what you read through. Can you share with us, please? Just share with us, please. Anybody, please, when you're coming to contribute to the topic, I want to know your name. And then your index numbers are already here, so your name, please. Because class participation and contribution also has a role to play in the ongoing assessment. So please, let's listen to whoever is there. It has been projected. Please go up. Give it a slow.
Sister, please, should I go again or it's okay?
I think it's okay. All this area we have gone through, so just read over it, and then we can go to. Please start from the definition of the normal labor. Start from the. No, we have done that. Go up. Please go up.
Of labor.
No, starting from the factors that affect labor.
Factors that affect first stage of labor. Difference between truth.
Let's go ahead now. Please go ahead and read it.
Okay.
It's up again.
Okay, you say what?
Latent phase or predominant phase.
Factors that affect the passage of pelvic architects. During labor, the fetus assumes positions and attitudes that are determined in the past by the configuration of the mother.
Good. Please read and then explain it to them. I'm just taking my breakfast. So you read and continue explaining. When I'm done, when I finish it, I will join you, please.
Okay. The passenger. That is the passenger of fetal size. Presentation and position, as well as the placenta and importance, as well as the placenta, are important factors in the conduct of labor. The passenger, it means, per my explanation, it means the fetal presentation, its position, and the placenta are all important factors during labor.
Good.
The powers or uterine action and cervical resistance. This talks about the force needed to push the fetus out from the uterus and includes primary and secondary powers. This means that, per my explanation, this means that during labor, there are some forces that push the fetus from the uterus, and it includes the primary and the secondary powers. Please, HAJIA will explain it well, so we can go through. The primary powers. The primary powers consist of all involuntary muscular
Please,
activities of the uterus.
please, I'll join you. I say I'm taking my breakfast. I'll join you. But then, if you say something and you can't explain it, there are lecturers and scholars among you over there. Call on anybody
Okay.
to explain it. They have an idea. They
Yes,
know it
sister.
very well. So let somebody, class participatory is also important. So let them be involved in the academic field, please.
Okay.
They can even explain, some of them can even explain better than.
Please, please, can you explain it to us? Anybody? If you have an idea about it, please unmute yourself and explain. The passage, the powers, the passage or the pelvic articulate, accept. Please unmute yourself and explain.
There are tutors among you, so please let them all. Let one of them take it up.
Rosemary, please
Hello.
mute yourself and explain.
Hello.
Please, I
Go
want
ahead.
to. Okay. Good morning. So, with the factors that affect labor, when we say the passage is where the fetus will pass. So we all know that the fetus will have to pass the pelvic cavity through the cervix to the vagina out of the body. So during labor, the fetus assumes a position and attitude that are determined in part by the configuration of the mother's pelvis. So the passage is the mother's pelvis. So the type of pelvis is a factor, and the position and attitude also determines how it will affect labor. So as we talked the other time, we have the true pelvis and the false pelvis. So if the mother is having a very good true pelvis, it will be easier and it will also enhance the progress of labor. That is how I understand. Then the passenger, as we know, when we take a cab, is who passenger now or for car. So that means that the mother is there. The passenger is the fetus and all the placenta and the membrane that comes out of it. So the passenger or the fetal size. So if you say the fetal size, when the baby is small, either the baby is small or big. You get it? And the presentation. So we are saying that the normal labor, the baby presents the vertex. And the position that the baby is is using to come out of the the passage, as well as the placenta, are important factors. So the passenger, when the passenger yourself. What are you saying?
Okay, so
the passenger, somebody said something, so I thought maybe I made a mistake. So the passenger is the fetus. So the fetal size and the presentation also affects labor. Either it will be delayed or it will enhance the labor. Then the powers or uterine action and cervical resistance. So the uterine action is determined on the contraction. That is the contraction. When there is a good contraction, you know that it will enhance the labor. And also cervical resistance. So when the contraction goes hand in hand with the cervix, it will help enhance the labor. So this talks about the force needed to push the fetus out of the uterus, and it includes primary and secondary powers. So when we have primary powers and we have the secondary powers. So the primary powers is what the physiological aspect that we talked about, and the secondary powers is what the mother will put in, the effort the mother will put in. So if everything is good and the mother puts in more effort, it will make the labor progress very well. So the primary powers consist of involuntary muscular activity of the fetus, that is of the uterus. That is, the uterus is doing its work. That's the primary force moves the fetus through maternal pelvis during the first stage. And the messages are covering. Then the secondary powers is also made up of the voluntary contraction of the thoracic diaphragm. That is, the primary one that will enhance or affect the labor. And also, the messages are Okay, and also the abdominal muscles and pushing efforts of the mother. That's mother adds voluntary pushing force of the contraction during the second stage to propel fetus through the pelvis. So in this, we could identify that the primary powers is mostly during the first stage, and the secondary powers is mostly during the second stage. The patient or provider, it is assumed that the physician factor is significant in the effective management of the normal labor. So physicians may influence by the patient's attitude, the time of the day, anesthesia support, the medical legal climate, and their own training and experience. The patient's level of anxiety and pain tolerance may also influence the character and duration of labor. So as we, the midwives, what are we doing to help the mother and also enhance or progress the labor? The mother, most of the time, most of them don't know what they are doing. So with your encouragement, with the position that you help with the mother, that will also help affect labor. Thank you.
Thank you. Chapter 2. Clinical decision
Wonderful.
making.
Please let me applaud to the lady. What's her name? Please, your name, the one who explained it.
Please, I'm Adelaide Champon.
Adelaide, I'm so grateful. I think you continue explaining it. When you are stuck somewhere, I'll come in. But she has done a very good job. One thing I want to add at this point is that with regards to the mother's efforts, talking about the secondary powers that the mother is using, when the woman comes and the midwife refuses to feed her, which most of us we are guilty of, we don't care whether the patient has eaten or not, whether she's energized, so that she can even cope well during the second stage of labor. Some of us, majority of us, are guilty of it. So there are certain physical things that we have to put in place to ensure that labor is properly advanced. So that is the only thing I will add. Other than that, she did an excellent explanation with regards to the powers, both primary and then the secondary powers. Please continue. The lady, Adelaide, is she Adelaide?
Yes,
did she
sir.
Yeah, Adelaide, please continue.
Okay. Please, Gifty, please, can you continue with it?
Chapter 2.
Okay, so chapter 2 is clinical decision making. With the introduction, you say making good decisions consistently involves choosing options that have the best chances leading to favorable outcome. Decisions making can range from fast, intuitive, or heuristic decisions through to well-reasoned, analytical, evidence-based decisions that drive patients and clients' care. There is a spectrum of decision making. At one end of the spectrum, we use our intuition and experience to make decisions, where there are typically a high volume of simple decisions to make. So what I can say about this is a clinical decision that you are making. So when the mother comes, so you are saying that it is 10 cm. You have why a V in one who say pelvic, you don't feel for any ischial spines before you tell the mother to push, because you know the presentation. It is a presentation in not a woman pushy bar ebe harding. Please, I don't know if we get it. At the other end of the spectrum, there may be complex decisions to be made where the level of uncertainty is high, and an analytical and evidence-based approach is needed to support the rules-based heuristics or experience we have gained over time in similar situations. So let's say that the mother comes or presented with the breech presentation. So with your intuition and clinical decision, you know that there you do it and help enhance the the labor. So if you cannot, you should make a decision at that time. You don't let the mother go into the labor. Ebe affect labor. Ebe the second stage in check. And that's ebe labor na eden. Ebe ha labor no. So what is decision making? A decision is the point at which a course or action is determined. The internal process by which a course of action or inaction is chosen. And that's the reference, Mark 4, 2015. Decision making is the process of developing an answer to a particular problem, making sound decision based on individual and group decision. And group decision making is principal for midwifery due to the fact that professional choices directly influence people's well-being and life. So this is self-explanatory. Decision now be making, either it will affect the mother or it will help the mother. For example, administering the wrong dosage of a drug will lead to a deadly outcome, affecting the client and the family. So if the client is affected, my wrong dose and the client is affected, it will also affect a family as a whole. The quality of the care that is provided by midwives is directly related to the quality of decision-making process. And that's the reference just for 2022. So poor decision-making is a theme. Please, can you stabilize the screen? Poor decision-making is a theme evident in confidential inquiries and adult reports, including that poor clinical decision-making contribute to poor maternal and neonatal outcome. So we know that in midwifery, everything that we are doing is based on research. So the obiaya abuano, and then I want so yeah then. Also, oh yeah, man abuano. So if we don't learn from the decisions of other people, so it cannot not only be you, only your colleagues now. If you see something and you're comfortable or you don't understand, you have to ask other people so that it can help you in your clinical decision making. Thank you. Type of decision making theories. All right, please, I will take my time. Type of decision making theories considered. So one, descriptive theory is concerned with each individual's moral beliefs regarding a particular decision. This approach describes how individuals reach their decision and its process focus. Please, someone can also help? This is a very good point. It says it deals with the moral beliefs regarding a particular decision. Someone can also help. You can unmute yourself and take that point.
Hello, sisters. I want to contribute a little.
Okay.
In the decision making like this, the more the religious belief, the client, maybe example, when he's a Muslim and he comes, maybe you want the partner to be with her. So you, the midwife or the team should allow the partner to be with the client because it's her religious belief. Maybe they don't do anything without the partner, especially the Muslim. When you are going to do VE, they want the partners to be around. Other than that, if you don't allow them, they can do something that will maybe later hurt the fetus, or maybe the outcome will be destroyed. So we should consider their moral and the religious belief too. Thank you.
Thank you. Please, I hope we all get it. So we are moving on to the second one. All right. Normative theory. Okay. This approach assumes the individual is rational and logical and is concerned with how decisions should be made. What is important is how good the outcome is. Thus, connote what decisions individuals should make logically. Please, someone should help us with this too. so that it will be interactive. Thank you.
So, okay, with the normative theory, we are talking about rational and then logical decisions. So let's take, for instance, when a pregnant woman comes into the maternity ward with a low fetal heart rate, and then the position of the baby, the lie of the baby is not the right form. Now we are looking at two things. The lie and the presentation of the baby is not accurate. Let's say the baby comes in a diagonal position. The baby is in a oblique, is presenting with the buttocks, which is the breech presentation. The baby is in a diagonal lie, and then fetal heart rate is also low. It means that if we don't make a rational decision about it, if we don't think about it and then make something happen at the moment, when something like that happens, the first thing that comes to mind is CS, emergency CS. So if you don't take action at that moment and then proceed to get the CS for the patient, you might lose the child and then cause adverse effects to the mother as well. So with the normative theory, we are thinking of the approach that will solve the problem that instant. That's what I think of it.
Please,
Thank
can
you
I
very much.
add up?
Oh, yes, you can.
Okay, so this is how I understand it. With the normative theory, it says that every individual is rational. That is, we make reasonable decisions, right? So if the client comes and the decisions that they are going to make, it should be reasonable and logical, as in meaningful. So if the decision that they are going to make, let's assume that when he obi oho baha with the religion way obi obaka say ibia me dem pese meye CS or something, although the person has the ability to make the decision, but once they all can ibia oba no to say the previous sister ne kind ibia line no ibia the person the baby is presenting with breach, right? Into oba and him say fetal heart rate no enko enye good until I was saying any CS, but meanwhile this person say omo CS and all that, or right so be making decision need do, but if the decision is not applicable, if it's not reasonable, that particular moment now and the can say ye jaima or non because the outcome would definitely not be good. That's how I understand it.
Thank you very much. So I hope
add up something.
Okay, if you want to add up, you can.
I just want to draw attention to it. It's like everyone is talking mostly about the clients, but what I think of this is that when it comes to decision making in this chapter, it's clinical decision making. It's what decision you, the midwife, is taking, even before the client brings his or her idea. When you look at the descriptive theory, it's talking about what you, the midwife, the decision you make. So it's mostly first about us before the client. So I think what decision making is talking about here, all the types are talking about what you, the midwife, do. First hand, you, the midwife, what you do before the client. So let's throw more light on what we, the midwives, we think on first before the clients. Thank you.
Thank you very much. So from what our sisters are saying, we will gather all of them and we will take it into consideration. Thank you. So as our last sister said, it's a clinical decision. Into who midwife, once you hear second line or say, what is important is how good the outcome is. Say being a mother, na yenya baby no. And then now because who midwife no, so na sa wenya omuba kwampa. It's you feel that you didn't make a good clinical decision. Thank you. Thanks to our sisters. So the next one is a prescriptive theory. This encompasses the policies that govern the remit of a decision within the evidence base that informs the practice. Into one say first line, you call say policies that govern the remit of a decision within the evidence base that informs the practice. This approach attempts to improve decisions. Examples are policies and protocol. Please, we need one person to highlight this. This one is where you'll be able to see content.
Hello. What I understand about this one is that what they are trying to say is it's a protocol within the clinical practice. Meaning, for example, if the protocol says if somebody has a CS less than 2 years and the person is pregnant, the person has to go through another CS. Meaning, there's policies and protocols govern such situation. That's the way I understand it.
And
Thank
also
you.
to add up, concerning the policies and the protocols, we the midwives, we use the pathograph as our tool for labor. So if the hospital protocol says the client should not cross, let's say, 8 cm twice or 4 cm twice, and you are like, let me wait and see if she can push through. If the protocol is if the client is not to repeat that centimeters twice within some given hours, the client should be rushed to the theater. You understand? Meaning you should not make your own decisions, but you should rather go by the hospital protocols and the policies. That the pathograph says the client should not cross 6 cm twice, 8 cm twice within a given time. That is how I also do understand. Thank you.
Thank you very much. Our sister Abigail Apia also raised her hand. Abigail Apia. Abigail Apia. Or you don't have anything to say again? All right. So, hello.
Hello. Like my sister rightly said, it deals with all the protocols that we have in the various units, either the ANC, the labor room, and the line in. We should implement all the protocols well. We shouldn't neglect the protocols.
All right. Thank you. Thank you to all of you. Okay, so we move on to. Please, I hope you all get it.
Please,
We are
my
moving.
hand is raised. Can I talk, please?
Okay.
Please, I would have to take us back to the descriptive theory. Just like one of our sisters rightly said that it is clinical decision, so it concerns us the midwives. It says that which it is concerned with each individual's moral beliefs regarding a particular decision. So let's say a client comes to you, the person may need transfusion, moral beliefs, and maybe we know that some of our Jehovah Witnesses don't take blood. So because maybe you are from that denomination, you think it is not right for the client to receive blood. Because of that, you will not give the blood to the client who needs it. I think it is like talking more about such scenarios, and that wouldn't be appropriate or at that time good for our clients. That is what I wanted to say.
Hello.
Okay, so
with what our
are
sister
you
is saying,
saying?
with
Hello?
what our sister is saying, we are talking about the types of decision makings, clinical decisions making. So in every aspect of our routine or our time on the ward, there are certain situations that you find these types of decision making theories where they will come into action. So with the descriptive theory, when it comes to Jehovah Witness clients, you see, you are going to use the descriptive theory to them with how they believe. You get it? But with the normative theory, you, the midwife, you are going to make the rational decision. You are taking a step. You are taking a major step to help the client. And then with the descriptive theory, the individual has her own belief. You get it? And you as the midwife, you must be concerned with the client's belief that she is bringing out. And with that, you come together and then you create a more welcoming decision that will help solve the client's problem. Please, do we get it?
Oh, okay. So, sister, please, it's not like because me, the midwife, is a Jehovah Witness, I don't want to give the blood.
No,
But
no,
it's
no.
rather,
You can't base on your belief and then prescribe how should I put it? Prescribe a solution for the client. You can't.
Hello.
I don't know if
Hello.
I'm making sense.
Hello, please. I think
Please,
what you are making sense, but
if you
what the
want to,
first lady said is some way or somehow right. It's talking about the midwife, although she doesn't. What the point is talking about is you, the midwife, should not use your moral beliefs to make decisions for the client. So it's not about the client being a Jehovah Witness. It's about the midwife being a Jehovah Witness, trying to impose her moral belief for the client. So I think
No,
that
I was making a different scenario. I was putting out a different scenario.
Oh, okay.
Hello. Yeah, I think the lectures has been so much interesting. People are sharing ideas and experiences. Yeah, it is very good. So we can continue to share our experiences and other things. But this particular point that you are talking about with regards to the decision making and the beliefs of the midwife, that some midwives can even impose their religious beliefs on the patient or on the work, so that it comes to a point that where the decision making is wrong because of her spiritual belief. She thinks we should go, the midwife thinks that we should go by her belief. A typical example is where a patient had PPH, severe PPH, and in fact it was a traumatic PPH because the uterus, had ruptured and it has torn roughly beyond the repair. And so that they will have to do hysterectomy. And this patient, because of the bleeding, it's like the patient needed 2 pints of blood, which the patient refused to accept. Now, when the patient was sent to theater, whatever decision that the medical team or the obstetric team took was that the patient needs to be transfused. Other than that, we are going to lose that woman. Though we had the baby, but the patient, if you are not taking good care of the patient, not good care per se, but if you don't transfuse the patient is going to pass on. But this midwife who conducted the unfortunate aspect is that she conducted the delivery. I don't know for what reason. At the end of the day, uterus has ruptured. We are going to do hysterectomy. Then do you know what she did? When she heard of the blood that they are going to transfuse the blood, and she is also Jehovah Witness, she managed. This is the real story. Those of you who heard it, they know what I'm talking about. I don't want to mention the facility's name. It's a real situation where this midwife managed to get theater gown for the husband of the client, dress him up, and then for the husband to go to theater, she led the man to theater. And so when they had given the lab man brought the blood after they have donated, then the man said, no, the doctor said they should set up the blood because the condition wasn't good. But this man came, I don't know whether I would say he went in at the right time or by the guy or the directives from the midwife. Then he got there and then he said, doctor, please hold on, don't give my wife the blood transfusion. Don't give her the blood. Then the doctor said, what? Who are you? He said, I'm the husband of the client, the woman on the table. We are Jehovah Witness and we don't accept blood. Then the theater boys got up. They said, look, if you don't leave this room, we are going to call the police. He said, I'm not going to leave. In the first place, who gave you this theater dress? The long and short of the story was that they have to call in the police. Police came to the theater to pick up this man before the woman was transferred because the HB had gone down to 4 grams. Can you imagine? A whole midwife did that. This is a real story I'm telling you. It's not a fake. It's not that I heard it from somewhere. I was there. And I don't know where this midwife is at this moment. If she's also listening, she'll feel guilty. So at the end of the day, the woman was under sedation. The blood was given. Even after the blood, 2 pints of blood, the HB came up to, I think, 7 grams or 8 grams thereabout, just to keep her surviving. So what is the guarantee that this man will not even leave the woman and go and marry another woman if we don't even give the blood transfusion? What is the guarantee that if the woman dies, the man won't go in and marry another woman? You see, all these things we are sharing with you, that is why we are talking about clinical decision. But the decision that midwife took was solely wrong. She shouldn't have done that. She shouldn't have done that at all, but she did it for the sake of her religion. Can you imagine? What if the woman decides in future that I don't want to be part of that religion again? But if she doesn't survive, where will she be to take a decision? I hope you are getting it. So let's not drag so much on decision making. In midwifery arena, we have to make sure that the decision that we take is in favor of the patient. In fact, if that woman were to be able to talk at that time, and she said that I don't want the blood, you cannot side with her that don't take the blood and then die. Let us sign a consent form. Let us sign a consent form. I don't want to go into details because I personally was sent to court because of this Jehovah's Witness issue. Personally, the first time I found myself in the docket, the first time, all because I was ready to donate for a boy, a 12-year-old boy, whose HB was 3 grams. But they said the Jehovah's Witness, they don't accept blood. That day, that was the first day I cried in my life as a nurse midwife. Because the boy said, Ma, so you allow this woman to donate for me. You are looking at me. You want me to die? And he was saying it, Clement, I'll never forget this boy. He was saying it with difficulty, so dismic. HB 3 grams. So the following day, I left with tears. I was crying like a baby. I left. The following morning, I went there. I said, I want to go and see this boy. What happened to him in the morning? I went, the bed was outside. The boy died in the night. We are talking about those of you who are Jehovah's Witnesses. We have to be very mindful when it comes to sectants. That was why the doctor said, no, this couple, I will send them to court. I will report them to the police. And just because I said I was ready to donate and the boy said no, the couple said no, and the boy died. That was why I found myself in court. Just to confirm that, is it true I was ready to donate? You see, when it comes to blood transfusion and this Jehovah's Witness, we are not rebuking your faith. But let's do things right as professionals. Let's do things right. Who even knows that this boy, after he had grown up, would have remained Jehovah's Witness? What is the guarantee? But they left him to die. So let's be mindful when it comes to midwifery, because we know that midwifery and blood transfusion, midwifery and blood, that one is part of the profession. So let's be mindful when it comes to blood, giving of blood to save life. That is the rationale behind the whole thing. Thank you very much. I hope you have understood. Let's move on because labor entails a lot. Any questions so far? Any contribution? The one who has explained, can you go ahead and then read and then we explain so that we can move fast? Go ahead, please.
Okay, sister.
Unless somebody has a question to ask. Unless there's a point that somebody wants clarity, then I can explain it. Other than that, let's move on. Go ahead, Lydia. See it. Go ahead, please. Whoever is reading.
About the nominative theory.
Are you making a point? Is somebody making a point?
Continue. Adelaide.
Please continue, please. Let's
Okay.
move on.
Okay, sister. So we are going to the decision-making models. A decision-making model is a process used to guide teams to make decisions that can benefit their companies. Each model uses different methods to help you analyze and overcome a challenge.
Straightforward.
So, yes. So, common types of decision-making model. The first one is rational decision-making model. Rational decision-making model. So, rational decision-making model is making choices while thinking rationally. Rational decision-making will often follow a method or process to reach desirable outcomes.
Good.
Rational
so like the example that, the example that I gave you concerning that midwife dressing a patient's husband to go in, is it a rational decision making? She's considering their religious belief and nothing else. Not the life of the woman, not the health of the woman, but her spiritual belief is what she associated it with her work. And it is not right. It is not right. You see? Continue, please.
Okay.
Continue.
Rational decision-making employs the use of logic over emotions while making decisions.
Good.
It has 6 steps. So the first one is define the problem. Define the problem. Aja, please, should I read? Should I continue or you explain?
Oh, defining the problem is, we can still go by the example that we gave. When you are to define the problem, you define it and then think about the consequences of the definition that you are giving to it.
Okay. Identify the criteria you will use to judge possible solutions. Identify the criteria you will use to judge possible solutions.
Good.
Then, thirdly, you decide how important each criteria is. Then you generate...
that midwife who took that decision, did she consider the importance of the decision that she took? Please, I'm asking the whole group.
No.
Was it right?
No, HAJIA.
No, HAJIA.
No. She didn't consider the importance at all. Okay, continue.
Okay, so you generate a list of possible alternatives.
Good.
Then you evaluate those alternatives.
Yes. You generate the list. Possible, is there any other possible way of going about that issue? You have conducted delivery. The woman has ruptured her uterus. They are going to do hysterectomy. Now, we are talking about evaluate those alternatives. Even if there's any alternative, the only alternative that she could have discussed or suggested is the use of other isotonics, or how do you call it? Those infusions that we set up, and it's like it behaves like giving blood transfusion. How do you call them? How do we call them? There's the Inferon and other drugs that they can set up. There's a new one in the system.
Iron sucrose.
Iron sucrose, okay. But at that time, it wasn't enough. It wasn't enough to save the patient's life. Because apart from the hysterectomy, the uterus that has torn roughly is beyond repair. Now you say, because we don't accept blood, I won't allow you even to remove the uterus. The decision is wrong. So when you are taking a decision, think about what will save the life of the client and not what you believe in. Okay. So go ahead, please.
Then you determine the best solution. Then after that, you implement the decision. Okay. So the rationale, okay.
So let me explain this one. So you said then later you implement the decision. There was an instance, there was one particular doctor somewhere that we were working with. It's like she's that kind of a little bit of lazy type of doctor, right? So when a patient, when there's fetal distress, you, the midwife, you are anticipating that if cesarean section is not done, the woman is likely to lose the baby. Then, so when they go to call him, then you say, oh, go and try. You set up infusion, monitor, and let's see. You continue doing that. So here came in a patient who has been treated infertility for so long. She's been able to achieve pregnancy. She's in labor. And we wanted the woman to go through the CS so that at least you get this baby for the first time. Doctor said, oh, no. So when they went, then there was one midwife who took the file, the folder of the patient. I went to him and said, please, the baby is in distress. You know what the doctor told her? He says, you yourself, you the midwife, you are rather in distress. It is you who is in distress. This woman, she will make it. He said, no, she can't make it. If you think you can't do the cesarean section, please, let's refer the patient to Sunyani Government Hospital. So that at least for the first time, she'll get a live baby. You see? This is a decision that the midwife thinks that it's a bold decision, though, because that facility was also equally a very big facility. Why should you, in the first place, why are you referring the client? But it's just because of sheer laziness of a colleague team member. You see? But she took that decision and then told him that if you are not ready to do this section, then we are referring the patient to the nearby facility where they can do the CS for the woman to get a live baby. It's a decision. She knows that it is something that will help the client and help the baby. And of course, the family. So these are some of the decision makings that we are talking about that determine the best solution. So that you don't behave like some midwives, everything say, yes, doctor, yes, doctor, yes, doctor, yes, doctor, and then the patient is dying. Everything, yes, doctor. Come out with your decision. Yes, doctor, but please, may I suggest something? I want to suggest that let's prepare. We have prepared the woman. Can you come forward and do the cesarean section? Or I'm going to document it down that we called you at this time and you refused to come. I'm going to write it down so that if there's maternal audit, if something happens to the woman and there's maternal audit, then you will come and answer. You talk like this, and then the doctor will even respect you. She will know, he or she will know that, yes, you know what we are talking about. We are not fighting. We are all there for the interest of the patient and their babies. Please, I hope it's clear. Can we continue? Shall we make a headway?
Yes, Master.
Okay. So finish up with the rationale model.
Okay. So the rationale model lessens a lot of factors like faulty assumptions that can lead us to bad decisions. It can minimize risk and uncertainty. However, it's not the best model to use when you are under time constraints or in fast changing situation. It is also important to remember that you won't always have all the information you need to use this model. And if you do, going through the full process isn't efficient or necessary for some decisions.
Explain. Please explain it.
Okay, so Gipsy, please, can you give us the other slide? So it says that when you make a good decisions, it lessens a lot of factors. That is, so the important is it's lessons like faulty assumptions, like you are making assumptions which can be faulty, which can lead to a bad decision. And also another one is it can minimize risk and uncertainty since you're not using your own intuitions. However, it says that it is not the best model to use when you are under time constraints. So there are sometimes you have to do some things like quickly. So if you don't have enough time, you are not going to use all the models. You are not going to go from the 1 to 7. You can even like define the problem, then you go and make the best solution. You don't wait to the second, to the third, and to the fourth. And also it says that it's also important to remember that you won't always have all the information that you need to make the decision. So I think that the clinical decision, when we were starting, it says that you want a good outcome, that you want to save the mother and the baby. So if you think that the decision that you are making, it will help save the mother and the baby, you don't wait to go through all the criteria. You go forward to the end part of the decision making. Okay, so we are going to the next one. Bounded rationality decision model, or making good enough decision. According to this model, individuals knowingly limit their options to a manageable set and choose the best alternative without conducting an exhaustive search for alternatives. So it's saying that this type of model is making a good enough decision, that you don't wait to exhaust or search for other alternatives. So as HAJIA gave us an example, that the alternatives that they needed at that time was to transfuse. At that time, they needed the transfusion at that moment. They don't need to wait to go and get the other alternative of blood, because that won't solve that problem at that time. So let's say when the person needs blood transfusion, a drop cramp, and yes, having a alternative, use the thing that you need at that moment. So this is what I understand by this model. An important part of the bounded rationality approach is the tendency to satisfy, which refers to accepting the first alternative that meets your minimum criteria. The first alternative that meets your minimum criteria. Satisficing is similar to rational decision making. Rational decision making, but it differs in that rather than choosing the best choice and maximizing the potential outcome, the decision maker saves time and effort by accepting the first alternative that meets the minimum threshold. So I think that this one is going for the first alternative to save time, that you don't need to put all your alternatives there before you pick them one after the other. If you know that your aim is to save mother and baby, and the first alternative that comes in mind will help, you use this method rather than waiting to get all the alternatives before you use it. Please, I hope you get it. Please, should we go on?
Yes, please.
Okay. So the next model is intuitive decision-making model. It refers to arriving at decisions without conscious reasoning. The intuitive decision-making model argues that in a given situation, experts making decisions scan the environment for cues to recognize patterns. So this one is talking about intuition, like how our dream without conscious reasoning. Once a pattern is recognized, they can play a potential course of action through to its outcome based on their prior experience. In the area for a previous experience that you have, you go on, so facing the same situation, you see your intuition, and you have to compare alternatives. Now they are solve that problem that you face at that time from the previous experience that you have. Once a pattern is recognized, they can play a potential course of action through to its outcome based on their prior experience. Due to training, experience, and knowledge. These decisions have an idea of how a well-given solution may work. Novices are not able to make effective decisions this way because they do not have enough prior experience to draw upon. Please, I hope you get this one. So this one is talking, I think this one is talking about intuition. At the end, what you should be a farm out there. In that I will change other alternatives. If you think if your intuition tells you that it will help, you go in for this model. And we should note that it says that novices are not able to make effective decisions because they do not have enough pure experience to draw upon. We are moving on. Any question? Or we should move on? Okay. So recognition prime decision making model. So this is another model. So we should take note. We are going, I think this is the fourth model. The recognition prime model has a lot in common with the intuition model. Here is how it works. The decision maker recognizes a pattern in available information. They then pick a course or action and run through that action script in their mind. So he's saying that this one is moreover like similar to the intuition one. But while you're in what train, how we say so we should make we should notify the point. Okay. The next page says. So the third one is if the action script seems like it will work, the decision maker moves forward. If it doesn't seem like it will work, the decision maker either tweaks the script or ditches it and starts over a new script. In the area why beyond side the but situation now is similar and far. You don't force yourself to take it. So that makes it this new model. Like the intuitive model, the recognition prime model works best in situations where you can draw on deep experience or expertise. In those cases, it's an especially handy model to use when you are under pressure. Hello.
Yes, please.
Okay.
Yes, please.
So we are moving on to clinical decision making. That is deciding what information to gather, which test to order, how to interpret, and integrate this information to draw diagnostic conclusion, and which treatments to suggest is known as clinical decision making. So this is the definition of clinical decision making. That is the information, you are deciding on the information that you have to gather, the test, which test to order, and how to interpret and integrate this information to draw a diagnostic conclusion. So when the clients come and makes a complaint to you, you have to first gather the information. Yes, any panic say, Madam, me bo wana na wa twa drama no. Ebu ho grandpa na ebia ne physiological changes happen when a pregnancy. So you have to gather the information, which test to order. Okay, then you interpret it and integrate the information to draw a diagnostic conclusion. Please, I hope you get it. So as a midwife, you know that you are a prescriber. When the patient comes with symptoms, you don't prescribe drugs for every symptom that the person will give you. You have to gather all the information. You run a test that you think that it will help. Oh, this clinical symptom that the person is saying, may run a test where you're then you interpret it. Or interpret it before you integrate the information that you have gotten to make a diagnostic conclusion. Clinical decision making is a process that is fundamental to good professional practice. Yes, I talk fast. I talk fast, that's why, please forgive me. When evaluating a patient, clinicians usually must answer the following questions. Do the history and physical examination suggest specific diagnosis? Are there red flags that suggest an urgent medical or social issues that needs to be addressed prior to confirming a diagnosis? Should testing be done or consultations be obtained? Please, someone should help us with this. It says that when you are evaluating a patient, clinicians usually, and we all know that as midwives, especially those who work in the rural areas, we are more of a clinicians. You must answer the following question before you make a clinical decision. Someone should throw a little light on it. Please, I'm waiting.
Please,
We are waiting.
Please, mine is an experience. I was at the ANC and I was having a client who always come with cough. So one day I sat down and asked of where she is staying. And then per what the client was telling me, meaning she was staying along a lorry station and that road is not tiling and she sells at the place. So I told the woman to be wearing face mask. And since then, she didn't come with such way. So I think what we are saying is based on what I gathered, I was able to actually tell what the client should do, not necessarily a treatment. To my understanding, that's what I may say.
Thank you.
Can I also contribute?
All right.
Okay, so what I also understand by this clinical decision making is that when the clients come and you take the history, after taking the history, as you stated, an example is the client coming with cough. The client comes and tells you she's coughing. As you said earlier, you don't just have to write a cough syrup for the client. You just have to take issue. When did the cough start? Is it productive, or after that, then you do your investigation. You request your labs. Maybe the cough is an underlying symptom of another illness. So your lab will tell you whether it's just a real cough or is an underlying symptom of another sickness. After your investigation, then you give your interventions. If the interventions is beyond you, you call for help. That is, you refer the client to a further management place, maybe the doctor, or you request for more labs. So I think it is not just about you making the decision. If there is the need for you to investigate, you have to do. If there is need for you to call for help, you also need to do that. Thank you.
All right, thank you. We are moving on. The core skills of clinical decision making. Good, effective clinical decision making requires a combination of experience and skills. These skills include pattern recognition, that is learning from experience. So we have come to realize that the core skills, you should take note, the core skills of clinical decision making is two, from experience and skills. And the first one is pattern recognition. You are learning from experience, from what other people have reported to you or what you have seen. It will also help you in your decision making. Then critical thinking. That is removing emotion from our reasoning. Being skeptical with the ability to clarify goals. You examine assumptions, then you have to be open-minded. Recognize personal attitude and bias. Able to evaluate evidence. So with this one, as we mentioned with the theories that we were talking about, you need critical thinking. You don't, before you make the decision, you have to clarify the goals that you want to achieve. You have to be open-minded. At that time, you are a midwife. Your religious background is out. Your tribal background is out. You are making a decision that will help the client at that moment. Then communication skills, active listening, the ability to listen to the patient, what they say, what they don't say, their story, their experiences, and their wishes, thus enabling a patient-centered approach that embraces self-management, information provision. The ability, that is the ability to provide information in a comprehensible way to allow patients or clients, their carers and family to be involved in the decision making. So the communication skills that we are talking about, we know that as a nurse or as a midwife, you have to be a good listener. Mame, eya kakra, ebi kwampa na ye ne ya kese, ebi kwampa enye ne ya, but obesha da ka say eye ne ya. So you have to listen to the person with your eyes, with your nose, with everything that you have. That is why I think that the first thing is saying active listening. So the active listening is saying that you have to have the ability to listen to the patient, even if the patient is not talking. You have to have the ability to listen what they will say and what they will not say. Because maybe for example, as we were saying, you are saying something to the patient, you are asking a question, the partner is there. I also heard a gestures who say question now in the presence of the partner and an carer. So you have to consider what they don't even say. Their wishes. And also you get the information, how you embrace self-management, how they are able to manage themselves to give you the information that you are requiring. Please, do we get it?
Yes.
Okay, then we are moving on. Then the third one is evidence-based approaches. Using the available evidence and best practice guidelines as part of the decision-making process. So we have been saying evidence-based from nursing. We know evidence-based approaches. And evidence-based, the protocols that we have in our wards, they are what they have. Okay. So you have to add it before you can get your good decision-making. Thank you. The next one, or if AHJIA want to add, AHJIA, please, if you would add a little.
Oh, I think the explanation is well done. You've explained it very well. Unless somebody is having a challenge somewhere or somebody needs clarification, other than that, most of the points are straightforward that we've been using to practice. So I think we can move on. Is anybody having a point that needs clarity? Okay, let's move on. I like the way the elections are going. Class participation is very good, so that if there's marks that we are awarding, everybody gets it. So go ahead.
All right.
Go ahead, please.
So please, the next one is teamwork. Teamwork, I want somebody to add, because we know in our core values, we are talking about teamwork. So I need one person to talk about the teamwork in our clinical decision making. Thank you.
Please, can I talk about it?
Yes, you can do. You can. Go ahead.
Okay, so what I think about teamwork is that when you are in a setting and you are working with clients, you must work with sympathy and empathy. You put yourself in the client's shoes, so you don't have to be selfish. When you are managing a client, we are all learning. Even if you are working, you are still learning. You are working with a client and you need an assistant. Don't be selfish. Even if the person is your junior, you don't know what the information he or she has. You just go ahead and call for help. I always say calling for help doesn't make you ignorant. It rather boosts your capability. It helps a lot. So if you're working on a client, don't be selfish. Call for help. If you are doing something and you don't understand, you conduct a VE. You are not too certain about the dilatation. You're not too certain about the presentation. Call your colleague to assist you. Ask for opinions. That doesn't make you ignorant. It rather boosts your knowledge. Thank you.
Thank you for that wonderful explanation. That's good. Is it clear to everybody?
Please, Madam, yes, sir. Is your name Ivy?
Yes, sir.
Yes,
your name, the one who spoke just now, what is her name? What's her name?
My name is Claudia Amwa, but I'm using my husband's laptop. That's why it's Ivy.
Okay. Okay. So I think
HAJIA, please, can I also contribute?
Hello.
Yes, you can. Go ahead. Hello, please go ahead.
Okay, thank you. Most of the time when we talk about teamwork, we tend to think just around us, like within ourselves or among ourselves. I'm a midwife, so I'm just considering my colleague midwife. But when we talk about teamwork, we shouldn't forget that we have the multidisciplinary team or the interprofessional team. You may be a midwife prescribing a certain medication to your client or a patient, but you might have limited knowledge on that medication. There's nothing wrong with you contacting the pharmacist or the people at the pharmacy to give you in-depth knowledge with regards to whether you can give that drug to the patient or you cannot. And then also considering other interdisciplinary team members within the healthcare system. So the teamwork is not just about calling for help from your colleague, but it goes beyond among midwives and midwives, but other interprofessional team members as well. Thank you.
Thank you very much for that contribution. We have even gone far. Yes, please. I'm coming over. I'm saying that sometimes even common fetal heartbeat assessment, when you are listening to the fetal heartbeat, sometimes you listen to it, you can't hear it well. What prevents you from calling a colleague to come and confirm it for you? Yes. Most of the intrauterine deaths that we have experienced is because we are not working as a team. You listen to the woman's FH. It is irregular. And especially when it comes to a point that you don't even listen to the FH for 1 minute. Please, whoever is talking, can you mute yourself? If you decide to take that half a minute FH, some of you are learning to even you check it for 15 seconds, then you multiply, that kind of thing. You do that at the end of the day, the FH goes off. What is the guarantee that the last FH that you heard, and because you didn't count it for 1 full minute, the fetus is dying. The last breath is what you heard, and you took it like that. Some of you put the fetoscope on the abdomen and say, oh, it's there. What is there? It is not there. It is fading away. The fetus is dying. But if you had confirmed, if you had listened to it for 1 full minute, you would have identified the irregularities. If you had confirmed from your colleague, please, the FH is rough. I can't even hear it well. Can you come and also listen to it? That's a teamwork. She comes and then she also says, oh, the FH is not there. What you were hearing was just a uterine suffer. It is uterine suffer, the heartbeat of the mother. That was what you were hearing. The FH is not there. Then you can clarify from other obstetric team members to come and check. In that case, you are saving the life of the baby. Of course, the life of the mother as well. Because when the fetus, at the end of the day, if the FH is not checked well and the fetus dies, what happens? Fetus releases enzymes that will end up causing what you call postpartum hemorrhage due to hypofibrinogenemia. The fetus will die, mother may end up with severe postpartum hemorrhage. Now, what is the big deal if you had confirmed from your colleague to also confirm it for you? You would have saved a situation. So that is what we mean by a teamwork. Somebody may be working with a colleague in the same ward, they are not on good talking terms. They are not on good talking terms. At the end of the day, who suffers? It is the patient who will be the sufferers. So you see the teamwork that we are talking about. Let's try to bury our differences. Let's not send our social life into the work. So that together we work as a team, we save the life of the mothers, we save the life of our babies. Thank you very much for today. I've enjoyed the class because you have, it's like almost everybody is contributing, and that is perfect. That is good. So, Madam, continue. We are left with about some few minutes to go. So let's hurry up and then we can go.
HAJIA, please.
Yes,
I think I raised up my hand.
I didn't see it. Go ahead.
please, as we are learning, there is this thing that I observe. That's why many people also don't want to team up with others. Immediately you leave the ward, or why sometimes you are sitting there, somebody will be like, sister, please confirm the FH for me. Immediately you leave or behind the scene, they'll be like, you want somebody to assist you. If the person, it's most of us, that is how we behave. When you ask somebody to assist you, or when you are even calculating a drug, you ask for help. Then they sit down and backbite. So sometimes some people also feel shy to call for help. That is what I've observed. Thank you.
Thank you very much for that wonderful contribution. Please, if that is the situation, then I'm sorry, we are practicing midwifery in a wrong direction. There's something we call academic honesty. Academic honesty. If you don't know it, or if you don't understand something and you think your colleague can explain it better, why don't you invite that person? For fear that they may backbite you, they will talk about you. And don't be afraid of that one. If you know you are doing the right thing. A typical example is the FH that we are talking about. I'm not hearing it, but I don't want to call a second person because I think they will talk about me. Let them talk about you, all right? And save a situation for the clients. Because remember, a dead fetus can cause severe postpartum hemorrhage for that poor woman. Now that we are in the classroom, are we there with any of the mothers or any of the clients? No. That's why we are topping up. That's why we are doing our first degree. You will meet challenges. That's what that one is there. Don't be afraid of challenges. You will meet challenges. Fine, let them talk about you. Would you be a person will be yes, that is what you call academic honesty. You do that and you are saving life. If human being will criticize you, God knows that you are doing the right thing. So please, madam, continue doing the right thing. Continue doing the right thing. And also, you also have to keep yourself abreast with time. Sometimes, too, if you think they are biting you, they are talking about you. When you go home, you to read. Go back to your Margaret Mars, read, gather information. We have been telling our students to come along with a pocket.
I'm sharing about general knowledge and something I've been observing. That's what I'm sharing. It's not particularly about me. Why?
Yes, I know. I know what you are talking about. They all know what we are talking about. And I'm saying that don't give up. Don't say that somebody may criticize you and for that matter, you are not going to seek for help. Let them talk about you. That's what I'm saying. You let them say it. God knows that you are doing the right thing. And professionally, you are doing the right thing. It's better that way than to keep it to yourself. At the end of the day, the mother loses the baby. For all you know, that is the only child that she's about to have. I hope you get me. Who is on the floor and her line is breaking? Victoria Pia. Victoria Pia, how may we... Victoria, can you shift yourself a little bit? Your line is breaking. Yes. Go ahead.
Please, I also want to add up something.
Go ahead.
It's like we, the midwives, I see it to be like some of us are too knowing. We feel that whatever the outcome we get is the final outcome. Like we feel like we know better than any other person. So it makes it difficult for us to contact other team members to know if what we have is the right thing or not. Thank you.
Thank you very much. Please, overcomplacency is not good. Don't let us try to be overcomplacency. It's not good. It's not good. Whatever you know, somebody also knows better than you are. Hello?
Yes,
hello.
please.
The last person, and then we can, yes.
There was a same fetal heart rate that you are talking about. During the time of my national service, there was a woman who was labor. So it was during our night duty where I was supposed to go and check the fetal heart rate of that woman. So when I went, I realized that what I was getting is more or less like the maternal pulse. So I went to call one of our senior staff. That's true.
And what did she say? Hello?
was
You
even
went to
sleeping.
call the...
So when I went, I called on her, listened to this fetal heart rate. I went to call the staff who was sleeping, the senior staff. So when she came, she was like, "Oh, it's the fetal heart rate." So still, I wasn't convinced. I called on another staff. She also said this. So I was still standing with that pregnant woman where she told me that she begged. This same thing had happened to her.
She said what? She said who is dead? The baby is dead. Hello? Can you shift yourself? I'm interested in what you are saying. Can you shift yourself a little bit and get a clearer network? The network is breaking. Your network is breaking. Can you find yourself a comfortable place to stand? Are you in your room? You can come out of the room. You can walk on your corridor. Your network is not good. So I'm not hearing. Meanwhile, you are talking about something very interesting.
Her child. So if I can help her.
The network is not good. I don't know whether it is from my end. Go ahead. Yeah, everybody's interested in listening to what you are saying, but your network is not good. Are you Matilda or say Bonsu? Hello? Hello?
She's the Zoom user.
She's a Zoom user, yeah, but the network is not good from her end there. Did you hear what she said? Please, whoever heard her can repeat it for us to analyze it.
No, HAJIA, we did not hear what she
Sister,
said.
the network is bad.
Yeah.
I'm sure it's everywhere. Me, myself, I'm having difficulty hearing everything. It keeps on breaking. I have to be shifting myself.
It's rather unfortunate. Sometimes it does happen like that.
Throughout the room.
Yeah, sometimes it happens like that. The other group too, they experience the same thing. We are going to start with this. Yeah, I think it's now better. Go ahead. What did you say?
So when the senior staff refused to, I admitted that it's the maternal pause that she was also listening to, because I was a rotation student. So she assumes I don't know. She assumes I don't know. So after she left, this pregnant woman called on me and she was like, "Sister, this thing has ever happened to me before, and then I end up not getting my child. So please, if you can call a doctor so that the doctor can also come and confirm for me, because I've been trying to conceive and this is my second child." So I was like, so I went to call on this doctor, which he was also attending to other patients from another ward. So it took him time before he came. HAJIA, funny enough, when this doctor came and we assessed this client, there was truly no fetal heartbeat.
Oh my goodness.
Yes. And this same staff, I couldn't tell the doctor about what I experienced, what that senior staff did. So early in the morning, she came to me. She was like, "Ma, I know what to say." I was quiet. It was really hurting. So I was very quiet at the time. And I responded, yes. So sometimes this teamwork is very important because we are rotation staff. So it's assumed we don't even know what we are doing. Yeah. It's very bad. It's very bad.
Too bad.
There is a lot of problem where females alone, where we work, they're all females. There is a lot of problem because everyone is trying to prove that, oh, I'm very brilliant. I can do better. So this is a problem in the field.
So that is why I'm happy that these things are coming up. And that is the reason why you are upgrading yourself. Try to effect a positive change in the world, in your life, and among your colleagues. Please try to effect a good change. It's not easy to effect a change. That is one thing you should understand. Especially now that you are upgrading yourself. You try to effect a change, and these are some of the insinuations that they will be casting along. Was he any day? Was it not your first degree? was why first degree into was said that the new that there was a day. We see that kind of insinuation. But this is what we are saying, that never ever give up. Effect the good changes that we think it has to. But it depends on the individual, it depends on the approach, and it depends on how you go about it. If you know at first you were listening to fetal heartbeat for 15 seconds, now you have learned that sometimes the fetus is even passing on. And the last breath is what you listen to within that 15 seconds. What prevents you from listening to the FH for a full 1 minute? Like in her case, she was doubting. She listened to it for 1 minute, but she was doubting. And that's why she called for second opinion. And unfortunately, because there was lack of teamwork and understanding and overcomplacency, that is also killing some of us. That is where the woman, though she has lost the first child, this second time too, she has lost the baby. What do you think she will think of the medical team or the obstetric team? She will feel so embittered. And I don't think her third pregnancy, she would like to come to that facility to deliver. You see? So let's try to be good professionals. Because in midwifery, if you do the right thing and do it well, it is not human being who is going to pay. You get a beautiful reward that you least expected. You get a very beautiful and wonderful reward from Almighty Allah that you least expected. He will save a situation for you that you'll be surprised yourself. So, ladies and gentlemen, I'm thinking that we have deliberated a lot on this topic, this aspect of labor. Last week, I think we started with the management of first stage of labor. But now that we have spoken a lot about this decision-making and other things, I think it's enough. Let's try to do what is right. Let's put smiles on the faces of our clients. This woman that she just mentioned, I don't think she will go home smiling. We didn't put any good smile on her face. She wouldn't smile. She's going back home with tears. The secret tears that should have ended with a joyous moment. We couldn't compliment it. And now she's going back home empty-handed. And that is the second time. Please, ladies and gentlemen, let's try to be mindful when it comes to midwifery, labor, and its associate complications and other things. There are a lot of them that we can prevent. Let's try to prevent it. Thank you very much. Any question? Time is up. And I think we have done a lot today. I'm so happy. Those who contributed, please, I have your names and your numbers. It is part of your ongoing assessment. So I said, class participation, I don't joke with it. I've jotted them down. We add some marks to your marks when you contribute and contribute meaningfully. Then we can award you something. I thank you very much. Any question, please? Any question?
HAJIA.
Okay. Yes, sister.
Please, I have a
HAJIA,
question.
please, I have a question.
Yeah, ask these two last questions and then we can call it a day. Yes.
Please, I would like to know about the teamwork. I want to find out if we can add the relative to it. Because I remember we had a case, PPH case, and we had to assign one of the relatives to be a timer. And we also had to involve the orderlies. So I want to find out if we can add the relative to making it like we have a team.
Okay. Yeah, I would say yes, but it depends on the facility. It depends on the unit where the woman is kept. For example, you have only one delivery bed or two delivery beds in a single unit. That one, you cannot invite the relative's husband to be there. I think when the girl who was explaining it, the lady who explained it at first, she mentioned something like that. You cannot invite somebody's husband only to come and be viewing other men's wives' vulva. You cannot do that. But if the woman is in a single unit, a single room, then that one, even if the husband can withstand being there during second stage. Why not? You can involve them. I remember one of my past students, she managed postpartum hemorrhage alone. You know, PPH is something that you cannot manage alone. Bear it in mind.
Yes.
But she was alone on duty. And so there was nothing she could do. Then she invited the security man. She involved the mother. The mother should go with the sister to town, go and look for a taxi. She was referring the client to Confanoche. And then she assigned the security man that she should be doing the massaging of the uterus because she saw that it was PPH due to atony of the uterus. While she was seriously looking for the for the vein with her touchlight, with her phone in her mouth. Can you imagine? As a light, because there's no light at that time. And he said, I told the security man to be massaging the uterus. I told her, Papa, do you feel something hard here? Just massage it for me. So the security man started massaging. Security man saw massage your uterus. You can imagine the sort of massage that will go on. The uterus will have to contract by force. You see? And through that, the mother brought the taxi and then she took the patient to Confanoche. Luckily, she said she met the team there and then the woman was taken to theater. You see? So postpartum hemorrhage, you cannot manage it alone. Involve others. And that is also a teamwork. Unlike those who have been shouting at the clients, the mother is even peeping to see what is happening, and you are shouting back. You are shouting back. Yes, I mean, those kind of sarcastic words that comes out of your mouth. Some of us, excuse me, but not everybody does that. But some of you, you are shouting at the client. You are shouting at the mother at the same time. I'm talking about the client's mother. You did that and she can't come forward. At that time, you might need her help. But you are shouting at her, you are even to the extent of insulting. Which of the textbook is talking about insulting clients? You dare not do that. It's a rural midwifery. Practice midwifery in its rightful direction. Okay, so that is it. The last question, and then we can call it a day. Welcome.
HAJIA,
the last question. Yes, sister.
HAJIA, please, I want to contribute.
Please, my question is that we are looking at decision making, and then we are talking about instances whereby we shouldn't let our personal values interfere with the decisions that we make for our clients. But you might also be faced with a situation whereby the client's own values and beliefs are interfering with the decision that you have to make as a nurse or a midwife. We know for children, we have the Children's Act 580 that protects the rights of children. So we, the health professionals, can based on those acts and then intervene or decide for the child. But when it comes to an adult, like someone who is conscious and is able to make her own decision, how do we deal with some of these situations? Like assuming a patient comes and then you realize the patient is anemic, needs blood. This patient is conscious and alert and of sound mind, and the patient is saying, no, I will not take the blood. How do we make a decision in order to not to overlook the values and then the beliefs of this patient or the client?
Did the client give any reason, an example, excuse that makes it sensible for you to refuse rendering the services that you are supposed to give? So it depends on
the client is saying she or he is a Jehovah's Witness, and that her belief is that she doesn't take any blood products. But looking at her and your investigation, maybe her HB is so low that the only thing that could help at that moment is to transfuse. Should you go ahead and transfuse and ignore her beliefs, or what do you do in such a situation?
Please, once she's able to talk, let her sign a consent form. You should also document on her folder. Document it. Now that you're talking about she's severely anemic. Now, if in severe anemia, are they mentally sound? That is the first question I'm asking you. With severe anemia, you said she's mentally sound. With severe anemia, let's say 5 grams, is she mentally sound to take a decision? That is what that is what you have to think about.
They may
so
be
you document.
confused.
She's confused. The brain cells are lacking oxygen, nutrients, and other things. And so physically, you are seeing her to be in normal state. She's not. So whatever it is, in the first place, let her document. Let her sign. Even if she can't sign the signature, let her thumbprint. After all, she didn't come alone. The relatives are also there. Involve them. Involve them. One doctor will say, let's discharge her. But then you are discharging her for her to go and die. You can't discharge her like that. So document it and explain it to her. Madam, you need blood. You say you don't want it. I want you to sign a consent form indicating that you said it. So that if something happens to you, we shall have ourselves not to be blamed. You see, that is how we have to handle such situation. Then involve the relatives who are also in support of that kind of decision that the client is taking. Let them also come and document. Let them go and write a letter. You attach it to her documents. Then you inform the medical officer. You also document on the nurse's notes. So that if something happens to the patient, it is not you who has contributed to the death of a mother. After all, if she's not mentally sound because of the anemia, what about the other relatives who accompanied her? So it goes with the decision, the example that I gave you. Yes. Last person, please. It's time. I'm going to meet Group B. I'm going to meet Group B. They are already on the line.
Please, I want to ask a question.
Go ahead.
HAJIA, please, when it comes to a pregnant woman and the spouse, I want to know, is it most of the decision, is it based on the mother or is it the husband? Because there are several instances, especially when a doctor is counseling a client to send a client to theater. Mostly they said the wife has a 70% of the decision making, and then the husband is maybe 20%, and then the hospital has 10% in it. So maybe in a like the anemia, for instance, the person, they are Jehovah Witness. Maybe even previously the wife was also attending a different church because of marriage, and then she's going there. And when it comes, the HB is low, we need to transfuse. And then the husband said no. Maybe the wife said no, I want it. Which of them should we take? Should we consider? Because I know the wife has more of the decision than the wife. So now that we are doing this, so I want to know the appropriate decision, as if the husband says no and then the wife says yes. Which of them should I?
The husband is not her relative. That one thing you should bear in mind.
Okay. And as much as the client is giving the permission, it's the client herself.
Yes, answer her. Answer her. Let's listen to your answer.
Please, can I talk? The client has given her permission. A client in a body.
The one who said she wants to answer.
Okay. Please, I had an encounter with what my sister is saying. Last time you're having one client, she came in HB of 7.6. So she needs blood transfusion. But the husband said he is a Jehovah Witness. So he was able to convince the wife to not to accept the blood transfusion. So the lady and the mother was saying they won't agree with the blood transfusion. But we were able to convince the pregnant woman and the mother. So we told the mother that if her daughter dies today, the husband will get married, even within 1 or 2 weeks. So after the woman hearing that, she said, oh, okay, madam, so sometimes the way we explain things to the clients and the relative and how we talk to them will help them to make an informed decision.
Thank you very much. Thank you very much. I think we heard it all. We heard it all.
HAJIA, please,
please,
let me answer. Let me add to her.
Okay, go ahead. Your Group B is on the line. They are waiting for us to start. So,
my sister, when it comes to this decision, sometimes we take if the woman is in her normal state and she says, I want it, you will give it to her. But in some of the religions, the men are their superior and they take every decision from the men. That way, the man is going to pay. And the woman has entrusted her life into his husband's hands. So that way, you give it to her for them to decide. But when it comes to the doctor's side, and sometimes the doctors insist that they go and write a letter and thumbprint, stating that they themselves wish they want this. So if the doctor says this and you do it with your thumbprint, they will do it for you. But if the letter is not in and the client's life is at risk, that is when the doctor, the hospital too, will take it into their hands and save the person there.
Their last contribution.
Yo, go ahead.
My contribution is on the teamwork, involving the clients or the relatives in our teamworks. We were having a case, PPH, after delivery, and the client relative was there. The light was off, so we needed the client's husband to provide us with light. When he was providing us with the light, when he saw the blood, he was collapsing. So I'm contributing that we should know the work that we engage the relatives or the clients into when we need them during teamwork.
Hello, sisters.
So that is it. That is it.
Hello,
whoever is making that noise, you are lucky that the lecture is over. I would have put you into the waiting room.
Hello, HAJIA.
Yes.
Please, I want to add up. About the teamwork. I think that was 2018, 2019. I went for my clinicals at Dudwa Hospital. And this lady was on the second stage bed.
Hospital's bed here.
And
they will take us on.
Okay. Then this girl refused to push because she doesn't want the baby. She's a teenager and she doesn't want the baby. And as for the other thing, the maternity,
she wants the baby to die.
Yes, the maternity staff said they don't want to go for an audit, so the lady should push. So they told me to go and call the mother. As soon as the mother entered the second stage room, the lady just lied down and said, "Mommy, I will push." Just like that, the lady pushes. So I think that sometimes we need to involve their relatives about the teamwork. Sometimes it will work. Okay.
Yeah, it depends on the relationship. It depends on the way we talk to them. You know, some of us, we come to work already frowning our faces, as if we are on loggerheads with the clients, as if the clients should beg us for health services. You see, you do that and you don't expect anything better from the patient. Our attitudinal change. We should rather change our attitude and talk to the patient. I was a witness to where a client crossed her leg during second stage of labor. That this particular midwife, I don't want her there. And this client that I'm talking about was a midwife. I'm telling you, I have to be precise. She was a midwife. And she said, if this woman, and then that woman was her in charge. And everybody knows this in charge to be the kayiri boom boom type of midwife. She shouts and everybody's running away. And she came to deliver. The midwife came to deliver. And then it was her in charge who was on duty. And she was supposed to conduct the delivery. She said, lie. If this woman is here, I'm not going to push. I will push. And if the baby dies, I'll demand it from her. Can you imagine? So finally, we have to talk to the in charge to leave the scene. Before this girl started, she said, I'm in second stage of. I said, I will never push in the presence of this woman because she will shout at me. She will insult me. She has been insulting patients in my presence and she will do the same thing to me. So I don't need her here. Can you imagine? So it depends on our attitude. Some of us would think patients should beg us for health services. We think we are on top of everything. You can't behave like that and go scot-free. So let's change our attitude. Now that we are doing the degree midwifery, please let's try to be degree in whatever we are doing. I would like to say a very big thank you for your contribution, your attention, and all that you have been saying to make the lecture so joyous. I'm so
Thank
grateful.
you. Thank you.
Also, thank you so
Thank
much.
you.
So thank you. So I'll be waiting for
Thank
your
you.
other group B. Yeah, let me see how many of you attended lectures today. Let me see. Let me see. Okay, 729. But the other day you were 900 anyway. So thank you very much. Please, I'm leaving the page. I'm leaving the page. So when you go, please read on the money. I'm so much interested in the money. Please, did I treat the physiology of first stage of labor with you?
No, sister.
Yeah.
Yes, your other counterpart. Oh, okay. So then, please, I want you to read on physiology of first stage of labor, physiology of second stage, and then third stage of labor. Read the physiology, the physiological aspect, especially that of the first stage of labor, and then think about the management of first stage of labor. Okay. Thank you very much for your attention. Please, I'm leaving the page to join the other group.
Thank you, sister.
Thank you very much.
Thank you, sister. God bless you.
HAJIA, please write my name and add marks.
I've already, please, I've added it. It's your index number that has been appearing. I've added them.
Okay, thank you, HAJIA.
I'm so grateful. I'm leaving. Bye.
Bye.
Please, you did not write my name.
Sisters, wow, we need to when you be away stick at the group in you. What do when you say on Quadia? What does it stick at? Have a nice day. Bye bye.
Bye.